Welcome to another edition of the. And of course, I hope you've had a wonderful and restful weekend. As usual, we have a great show lined up for you tonight. If you joined us last week, we talked about the endocannabinoid system, and we talked about the endocannabinoid system from a historical perspective. And we had Dr. Rachel Knox of the Doctors Knox practice group. And she gave us a real in-depth look at the endocannabinoid system and how our understanding of it and the history of cannabis and the understanding of its physiology, the politics behind it, and how all of that sort of led to where we are now. We talked about how, doctors, say 100 years ago, maybe 200 years ago even, utilize, cannabis and other medications and other natural practices that stimulated the endocannabinoid system in a way that we don't utilize as much today. So today we're going to, bring forth that message, and we're going to be talking to Dr. Janice von Knox, who is also the Doctors Knox family practice and endocannabinoid medical practice group. And she's going to be talking to us about the science behind the endocannabinoid system. So this is really fascinating information. This is something that most doctors know very little, if anything, about. And I count myself in that group of doctors who know very little about this topic. But I'm learning fast. I'm a fast learner. So his last week's show enlightened me a great deal, and I'm sure this week's show is going to enlighten you a great deal. So stay tuned after this message. Okay, so I want to welcome my colleague and friend, Dr. Pam Atkins. Hello, Dr. Atkins.
Hi, good evening. Hello
good evening.
To everyone. Glad to be here.
How's your day going?
Oh, very, very nice. Very nice. Just trying to get going for the week.
Yep. So as you heard, we're going to have a nice discussion on this very fascinating area of medicine. And we have with us tonight a very special guest, Dr. Janice von Knox. Dr. Knox is a board-certified anesthesiologist, endocrinologist, and a certified cannabinoid medicine specialist. She is one of a family of 4 clinicians that believe science, research, and technology will disrupt healthcare as it has been known. The future of cannabis medicine will depend on how well the physiology of the body is known and the correct clinical application of pharmacology of cannabis and other botanicals is utilized. Welcome to the show, Dr. Knox. How are you doing this evening?
I'm wonderful. Thank you, Dr. Montgomery, and nice to be here with you, Dr. Atkins, as well. Thank you for having me.
Well, it's great to have you here. And the thing is that it's a mouthful to pronounce endocannabinologist, but I think I've gotten pretty good with it.
You did great. You did great. You did absolutely fantastic.
We've had a number of conversations over, I think it's been well over a year, maybe a year and a half. And I'm always fascinated by, the insight that you share with me about this topic. And I like in your bio, it's important to understand the physiology of the body. We in medical school and also in our practice, we look at health care from the standpoint of a disease state, and we use labels, the diabetic and the hypertensive and the heart failure patient and so on. But below these so-called diseases or chronic illnesses or whatever labels we want to give them is a physiology, and we would refer to it as a pathophysiology, patho meaning abnormal or pathological disease state. But there's an abnormal physiology that we refer to as a pathophysiology. But then there's a normal physiology that if we really understand those two in context, we can then say, okay, why is this pathophysiology existing? What's out of balance? And what do we need to do to bring pathophysiology into physiology? And so even in your bio, it speaks to the necessity of our perspective. Our perspective in the way we practice medicine is wrong in the sense that we're looking at the superficial aspect and really the outward manifestations of this pathophysiology. And so it's very refreshing to hear, you say that. Now, it's as we did for those who did not, join us last week. Can you give us a little blurb on a little bit of a history we got here? There's some, people understand Carnegie and Rockefeller, and give us a quick blurb on that history for those who missed last week, if you don't mind.
Oh, absolutely. And I think the history is so important because it tells us where we've been to where we are today, and hopefully where we are to go tomorrow, right? It gives us a context to build a different paradigm when it comes to delivering healthcare. But as we all know, cannabis has been used for thousands and thousands of years and made its first way into Western medicine in 1837, brought by William O'Shaughnessy to England and then to the American colonies, and was widely used in the mid 1800s to the mid 1900s, widely used. But there was always some pushback toward this medicine, whether it was spiritual or from government agency. There was always some pushback. But with that being said, it was widely used in America during that time. 50% of all drugs used both pharmaceutical prescriptions as well as over the counter. But there were some nails beginning to be hammered into that cannabis coffin, right? No predictable results, no constancy in the ingredients and how you store it. And so when they moved toward single molecular medicines like aspirin and penicillin, that became a nail in the coffin. And then moving further on into the US history toward the 30s, then we saw lots of pushback. And I want to say it's not because of cannabis itself, which we in America knew as cannabis, but it was because of hemp. You had industrialists like Carnegie and Rockefeller and William Randolph Hearst and Lamont DuPont wanting to get rid of this hemp plant that would disrupt so many of their industries, right? The paper, the textile, the oil, the fuels, disrupt so many industries. So they had a vested interest in getting rid of hemp. And it just so happened the Mexican-American War occurred. And so there was a bias against Mexicans who brought smokable marijuana across the border. They didn't smoke it before. It was all tinctures and oils. But they used the Mexicans and then the blacks to demonize this plant and to put fear in the American people so they could get rid of hemp. And I do want to say at the time, in 1937, when they were trying to pass this Marijuana Stamp Act, the AMA had a representative. And he was not only a lawyer and a physician, but he was an expert in drug policy, right? He testified that there was no danger to this medicine. It did have medicinal benefits and needed to be studied. They totally disregarded Dr. William Woodward's testimony, totally disregarded it and passed this Marijuana Stamp Act that put a huge tax burden on physician deliverers, pharmacists, and the growers. And then it was, of course, the onerous paperwork. And finally, to be kicked off the American Pharmacopoeia. Now, going on in the 60s is when we first got the first chemical structure for some of the major components of the cannabis plant. We'll talk about that in a minute. But in the 70s, it was enacted that no American university could do research on a cannabis plant. No American, and that was a huge, big blow to cannabis research. No American university. But in 1963, Dr. Raphael Mashula out of Israel gave us the chemical structure, the CBD. In 1964, he gave us the chemical structure of THC, alpha-9 tetrahydrocannabinol. It was with a synthetic isomer if they were able to radioactively tag the synthetic drug off the structure that was being built, right? Because you could not do research on a real plant. So they made a synthetic isomer, radio tagged it, and then just sat back and saw where these molecules worked. And what lit
And
up in
that's
the,
how they map the endocannabinoid system too, with the radioactive
that's
tags.
exactly right. What lit up in the brain in high dense numbers, more than all the other neurotransmitter systems combined, was this new neural receptor that no one had previously identified. And it was called the CB1 receptor, named
Wow.
after cannabinoids. Now, that's the first receptor, and that was in 1989. 1992, they came with a second receptor, and then the ligands that work on those receptors and the enzymes that create and break them down. Now, that's a classical description of the endocannabinoid system. The CB1, CB2 receptor, the two neurotransmitters or ligands, as you call them, or endocannabinoids, because they're made within our body, anandamide and 2-HG, and then the enzymes that create and break them down. That's the classical description. And the 1990s, in fact, was called the decade of the brain because no research, the volume, the amount of research done on the brain had never been done before previously. So they called the 90s the decade of the brain when they uncovered this amazing neurotransmitter system. The CB1 receptor is a neuromodulating receptor found primarily in the brain, in the central nervous system. The CB2 receptor is an immunomodulating receptor found in the peripheral tissues, like the thymus and the tonsils and the appendix. So these are the main receptors.
So you said something that I really want to nail down, and this concept of single molecular medicine.
Yeah.
So the thing is that, and as we get into the science of the endocannabinoid system, and really, I mean, we're going to be focused on the science of cannabis and the endocannabinoid system. But as you have pointed out to me in other conversations, your daughter did one of your daughters did a great job on a TED Talk about how many other aspects of healthy living stimulate the endocannabinoid system. We're going to touch on that as well. But I want to, for a minute, ask you to talk about this single molecular medicine and then contrast that with the actual power of cannabis and any other potential plant in terms of its more complete molecular, because it's a plant. There are things about it that we know about it and many things we don't know about it. But
That's
then
correct.
we substitute that, something that's complete, with something that's a single molecule that we take out of context, and we try to use that in health, and that's what's dominating what we do today. Help our audience kind of understand that, because we think of a pill, this medicine does this, that, and the other, but you're dealing with a single molecule that's supposed to do something in a very complex system that we don't understand, compared to a very complex molecular structure that we don't fully understand that's made for that system. Help us out with that.
Oh, yeah.
Concept.
Well, let me talk about the cannabis plant itself. It has over 400 pharmacoactive ingredients. It's really a little polypharmacy. And everything that's put in that plant is what we call full spectrum, every ingredient that's there. And those different components sort of modulate the other components. You know, you don't need one of them to work, but all of them work better together than separately. Now, when you get to single molecular medicines, all of them, for the most part, are ripped off of nature's plant, including aspirin that comes from the white willow bark tree. So it's a rip off of nature. So the further you get away from what's natural, the more you begin to see what I call the side effects of a drug. Because when the plant makes something, it makes stuff that works together, that works and binds together, right? And when you take one thing out and isolate it, what it does is totally different from what it was intended to do, because it's working in isolation. And we actually have graphs that show that when you do that, you narrow that window of safety for that product, instead of using the whole product that widens that window of safety. So you're narrowing down that window of safety when you use a single molecular medicine. So it's this bell-shaped curve that broadens when you use a multi-pharmaceutical or polychemical plant, versus narrowing when you use a single molecular plant. Now, what they don't get is that And this is true for cannabis as well, because we have the isolates in cannabis. Those molecules are what we call promiscuous, right? They work on numerous receptors, not just the classical definition of the CB1 and CB2. So when you're using that single molecular medicine, you may be affecting a number of receptors that you don't realize you're touching, trying to hit one target, right? And the reason why cannabis is so much better, because it has those other components in there mitigating and quieting down some of those other aspects of what that plant can do. So when we talk about the endocannabinoid system, and we talk about why cannabis works on that system, THC modulates what one of our endocannabinoids called anandamide does. And it works on that, what we call the CB1 receptor. But it works on that CB1 receptor, and if you take too much, you get the awful side effects. That's a single molecule that you're using. But if you use the broad full spectrum, you don't get those effects to the same degree. So that's the difference between using single molecule and a full spectrum product. You have multiple agents in this full spectrum quieting down some of the negative experience versus one that just hits it with everything it has. And the further you get away from natural, for example, take Marinol or Sesamet, which are the isomers of THC. Those side effects are magnified 100 times because it sits on that receptor so much longer than THC does, longer than our own endocannabinoid anandamide does. So the further you get away, the more you see.
So as I listen to you, it makes me think that the full spectrum plant, you have other things that create some kind of a feedback system where the receptor is stimulated. When it's enough, then it'll pull back or remove it. So it polices itself. It controls itself, the full spectrum plant. Is that a way of thinking of it too?
Well, yes and no. The endocannabinoid system itself is a feedback loop, right? It turns off neurotransmitters when you're overworking, and we call that excitotoxicity. So, for example, you have a stimulus coming down that axon and releasing those neurotransmitters that travel across the synapse through the postsynaptic membrane. And there they stimulate the production of those endocannabinoids that then travel backwards to the presynaptic membrane where the CB1 and CB2 receptor sits and say, turn off the signal, right? So that's what it does. So the endocannabinoid system is a negative feedback loop to modulate and control how neurotransmitters are released. Now, what cannabis does, it mimics or acts the same way as our endocannabinoids. So we can do the same thing to turn off those receptors. But what you see in the full spectrum is sort of quieting down the effects that you see. Once again, remember, cannabis is natural, but it's not natural to the body. The body does not make cannabis. What it does, there's other things in that plant will sort of quiet down other things by not only modulating how it works at the CB1 receptors, but it's hitting other receptors like the serotonin or dopamine receptors that help quieten things down. Because you don't only have cannabinoids in that plant, you have terpenes, you have flavonoids, you have amino acids, and all of them are working together to present a certain picture. So that's why. That's how it works. Now, you may recall a couple of years ago where they had an unfortunate incident in France where they had used a synthetic Fa molecule, which is the molecule that breaks down anandamide. They made a synthetic, and they were in their phase 1 clinical study, right? And they actually killed a couple of guys with this single molecule. And the reason why, because it worked everywhere. Now, what the endocannabinoid system does, when it makes its endocannabinoids, they're made locally and they're used locally. They're made on demand, made locally, and used locally. So my CB1 receptor in the gut is going to do something for the gut different than the CB1 receptor will do in the brain. So they're made upon demand. And when you put something into the body that comes from the outside, it just works everywhere.
Gotcha. So it's an overstimulation. So if we look at the endocannabinoid system itself, we're going to put cannabis on one platform, looking at endocannabinoid system itself. And I remember from previous conversations, you talked about stimulating endocannabinoid system. What are some of the natural things we can do in our lifestyle to appropriately enhance or stimulate endocannabinoid function?
And that's a beautiful question, and I love that question. because that's what the science has taught us, to reunite the body from our spirituality to our physicality, right? The things that modulate that endocannabinoid system, it's just not cannabis. This is a bigger thing than cannabis. And when I'm talking to patients, I tell them, first off, your first medicine is always going to be the food you choose to eat. That's your first medicine. So we look at, you look at your nutrition first. What are you eating? That's the first thing. Sleep. How important is sleep to the body? Exercising, yoga, acupuncture, meditation. Those are important things. They all modulate that endocannabinoid system, moves it back toward health, right? So when I'm talking to patients in clinic, we start from the beginning. We talk about their food, we talk about their spirituality, we talk about their relationships, because all of them will modulate the endocannabinoid system. And I like using an example, if you put a Band-Aid on an injury to protect it, but dirt still get into that wound, how good is that Band-Aid? Not very effective. Well, the same thing with cannabis. You can use cannabis, but if the patient is still, eating poor foods, not getting sleep, always upset, angry, and stressors, you're still not helping that endocannabinoid system. So it is a reunification of everything about an individual, from their spirituality to their physical needs, right? So it's the endocannabinoid system has taught us that we do really need to stop thinking of patients in silos. Stop thinking about the diabetic patient. Stop thinking about the heart disease patient, because all of them are controlled. Whatever disease process is going on is controlled by the endocannabinoid system. Now, these are the things that affect the endocannabinoid system: genetics, aging, pharmaceuticals, stressors in society, and the food we eat. Those are the things that affect your endocannabinoid system, that throws it in dysfunction. So if we do that, can we fix that?
Yes, yes. So let's take these one by one. Sleep, for instance. I'm picking on that because that's one of my weak points. We're told we need 7 to 8 hours of sleep. I mean, what has been your research? I mean, you're an anesthesiologist. You put people to sleep. What what say you on that? I mean, is that 7 to 8 hours, and not only just the 7 to 8 hours, but what are some of the mechanisms or our level of understanding of sleep as it relates to the cannabinoid system? What is happening to our endocannabinoid stimulation during sleep, the REM sleep, et cetera? What do we know about the level of effects of sleep on the endocannabinoid system?
Yeah. Well, I will tell you this. I haven't done a deep dive into the particular mechanism of sleep, but I will say this: sleep is so important, and I tell patients all the time, sleep is the time that the body reserves to heal itself. You get that diurnal release of the various hormones, which is controlled by the endocannabinoid system, right? And you can exhaust your endocannabinoid system by always going. So you need to give that body a chance to calm down and relax so that it can repair itself. See what the body does. The endocannabinoid system does three things. Number one, it keeps all your physiological systems in balance, including your hormones, so that diurnal change of those hormones need to be in check. It protects and it repairs. If you never give the system a chance to rest, then you have a dysfunctional endocannabinoid system.
Gotcha. So balances physiology, protects, and repairs.
Yes, balance,
Things.
repair, and protect. That's the job of the endocannabinoid system.
So going into the understanding of it, so I remember in our conversation, we talked about neurological function and how the central nervous system affects cardiovascular function, how it affects GI function and things like that. Is the endocannabinoid system on top of that central nervous system, or is it just kind of the glue that connects the central nervous system with the cardiovascular and all of these main systems?
I like to describe it as the foundation of all those other physiological systems. All the other physiological systems are built on top of that endocannabinoid system. And the bigger endocannabinoid ohm, right? Remember, the classical ECS or endocannabinoid system description are the two cannabinoid receptors their ligands and their enzymes that create. But the system is bigger than that. That ECS is just a part of a bigger, I call it the supercharged mechanism system, feedback loop that controls everything, including you have other receptors. You have what we call the vanilloid receptors, which are ion-gated receptors, channel receptors. You have the PPAR, which are nuclear membrane receptors. And those receptors are responsible for DNA transcription, fatty acid metabolism, glucose metabolism, tumorigenesis. It's responsible for so many things, even working at the mitochondrial level. So we're really talking about something that works at the cellular and subcellular level that controls all the mechanisms of the body. So all the various physiologies work in tandem. They work together. You cannot separate them. I just gave a talk on the endocannabinoid system and the skin, how the functional the functional ECS in the skin works and how it relates to the functional ECS in the gut, right? They're constantly working together to protect and keep each other balanced and functional. So you cannot separate it because it is controlling everything. And for the life of me, I don't understand how we can still teach physiology in any medical school without talking about the physiology of the endocannabinoid system, the endocannabinoid own. It's just, it escapes all logic to me.
Is it coming to the surface? Is this being talked about in medical schools, or
Yeah, I think more and more, but I think it's going to be up to us physicians, to learn more about it, even if we have to do it on our own, because our patients need this. They're going to come to you with that cannabis. Can I use cannabis for this? There is a level of competency that we as clinicians should gather so that we can support our patients, right? Big pharmacy is not going to do it. Big business is not going to do it. It's going to supplant too much of what they want, right?
no? That's a topic of itself. Big business, unless they can patent, which I don't think they can. What and we'll get to this on the clinical side, but where are we in terms of studying? I mean, I've listened to different lectures, and people say, we in the last 15 years, we've gained a lot of information on the endocannabinoid system. And I think the more you study something, the more questions come about. Where are we at this point with the understanding of the endocannabinoid system? Are we at a point where we can start to look at things such as, and next week we're going to talk about the clinical aspect of things, but things such as measuring endocannabinoid function or evaluating endocannabinoid function and treating it in a certain specific way? Where are we in terms of the science and its application?
Yeah, well, I can tell you where we are as far as the science. We know Dr. Ethan Russo described what we call the clinical endocannabinoid system dysfunction or deficiency. We talk about dysfunction now. So we can group it in two buckets: deficiencies and excess, right? Dysfunction. One bucket is deficiency, one bucket is excess. Things like fibromyalgia, migraine headaches, Parkinson's disease, PTSD, all those fall into the deficiency. And the excess are things like diabetes, insulin resistance, cancers, some autoimmune diseases. Now, as far as measuring the endocannabinoid tone of an individual, and by the way, each of us have our own specific endocannabinoid tone, and it is as specific to the individual as their fingerprints are. No two people have the same tone. So we really talk about the N of one. How does an individual respond to that therapy, right? But what we found out in patients with whether it's autism spectrum disorders or PTSD, they've done spinal taps, and they have found that there is a decreased amount of anandamide in that spinal fluid, sort of confirming the fact that these are endocannabinoid system deficiencies. But there's
I'm sorry, what did they find it's about deficient
deficient anandamide, low levels of anandamide. Okay, and then again in female health, which hasn't changed for 70 years, the answer is always cut it out. What they found, like in fibroid patients, they have low level of CBD1 receptors and low levels of FAAH that breaks down those receptors. So you're actually seeing true real-time deficiencies being described. And research is showing us more and more that we can connect disease processes to endocannabinoid system dysfunctions. So whether we really can't get measure it per se. We have ways of telling, where things are falling. But research is revealing more and more to us every day.
Gotcha. So basically, as I understand what you're saying, you have deficiencies within the cannabinoid system and excesses and things like diabetes or excess and fibromyalgia deficiencies, and you can kind of build those lists under those two categories.
That's
And
correct.
then we've seen in things like autism, lumbar punctures where you saw deficiencies in anandamide, which again is a deficiency of the endocannabinoid
Correct.
system. So I guess we're starting to get some level of understanding
That's
of
right.
endocannabinoid function as it relates to certain disease states.
That's right. That's right. Absolutely.
Interesting,
It's very,
interesting.
it is. It's fascinating.
Wow.
Fascinating.
So this is a really wonderful topic, and what I want to do is get back to the science of this. We're going to take a quick break, station break. We got a few questions out there as you're listening on. If you have any questions, ask Dr. Knox. Have them ready. I've got many questions to ask, and I want to get back to the measuring of some of these isomers and looking at deficiencies and getting some understanding of how these things relate to what we're doing as we sort of lead into next week's topic of clinical application. So y'all hang on for a quick station break. Okay, we're back here, and I'm taking notes here, so I'm in class. So there might be a test at the end, so I'm trying to prepare. Dr. Atkins, you and Dr. Pam, you and Dr. Floyd, do y'all deal much with cannabis or dabble with endocannabinoid system much in your practice?
Well, because we're in Texas and the laws, it's been limited, but mostly CBD. But I have had patients that travel to states where cannabis is legal and found it very helpful for cancer. I have one patient with pancreatic cancer and also appetite and chronic pain and anxiety. A lot of people find that it helps quite a bit with anxiety and rest and calming rest to sleep. So we're looking forward to perhaps being able to utilize it more in Texas.
Yeah, I think it's coming, and our experience has been similar to what yours has been, Pam, in the sense that we've had patients, of course, we use the CBD oil, but we don't use the THC because of the laws here in Texas. But it's very interesting in terms of how that works. So, from the scientific aspect of this, Dr. Knox, the deficiencies and excesses. I do recall looking at a lecture, and is a scientist out of Israel. I bet you know him. I can't think of his name. He's a bald guy. They run a lab there. They seem to do a lot of work, a lot of research there. And the one thing they're doing in their lab, and one thing he says, and this is on the cannabis side, is that they're trying to, understand the particular characteristics of cannabis. Cannabis is so complex. You get one concoction and it's hard to replicate it because you may not know what you have in one versus the other.
That's
From
correct.
the cannabis side of things, our level of understanding, where are we with the science there and trying to pinpoint these things and understanding what we deal with from one cannabis plant to the next, et cetera.
Yeah. Well, the first thing I'm going to say is that the cannabis is one plant, right? It's just
Okay.
one plant, Cannabis sativa L. And hemp and marijuana are very non-scientific terms at
Gotcha.
all. So we should be
Okay.
talking about cannabis. And the level of THC actually dictates whether they call it hemp or whether they call it cannabis, right? And in America, it's 0.3%. And in Europe, it's 2%, where GW Pharmaceuticals, that biomed pharmaceutical company, has cultivated a cannabis plant with 0.1%, and they would love to make that the standard. But with that being said, and you hit it on the head, Dr. Montgomery, is that each plant is so different. You know, you can grow a plant side by side, and that chemical makeup may be different. It depends how the light hit it, how the soil hit it, how the nutrients hit it, right? Will change the chemical composition of that plant. So we like to talk, instead of strain names, we like to tell patients, we want you to look for these specific cannabinoids. Which cannabinoid are you going to use, right? And I'm familiar with Texas law, so we have lots of patients travel to Oregon from Texas just to buy their products so they can get THC. But the difference is every plant is different. And so what they're doing in Israel is really trying to zero in on what cannabinoid or terpene is doing what, right? It's not just the cannabinoid. You have to talk about those terpenes. You have to talk about those flavonoids, those phenols, everything else in that plant that's doing its job. We talked about how the whole plant is better than the single plant. That's because we don't know which one is doing the work. Which one is actually doing the disease process, right? And Israel is starting to do those studies. And they had one study where they had a group of children on cannabis, a cannabis plant, and it worked fine to control their seizures. And they, I guess they ran out of supply and had to supply with a plant with the same name, but the kids started to seize again, right? And when they dug into it, they saw that the profiles were different. So they're trying to zero in on what is actually doing what. And we try to do that too, because what we do as a family, we travel around and listen to all the researchers. Now you have to remember, the researchers are focused in, their bird eye view is on their research, so they're not putting it all together. So we travel around and put it together, right? And so what we do when we look at a patient, we're looking at a patient, okay, what's the disease process? What organ is involved? What receptors are there at that organ? And what do we need those receptors to do? So we don't treat diabetes, we treat the dysfunctional endocannabinoid system by looking at specific cannabinoid profiles, terpene profiles. So anytime you're talking about cannabis sativa plant, or patient tell you sativa works better for me, or indica, or granddaddy purple, the next question is, okay, what's in that granddaddy purple? Because granddaddy purple in Oregon is going to be different from granddaddy purple in Texas than granddaddy purple in New York. So we really need to talk about those specific cannabinoids and what is doing what and where, right? And remember, if you put that cannabis in that body, it's not just going to hit the receptors you want it to hit. It's going to hit receptors all over the body. Whereas in reality, with the endos, they're made on demand, used locally, and then destroyed locally. So they're just hitting that one organ, right? You use cannabis, you're hitting everything, everywhere. So that's the big difference. That's why understanding and that plan is so important.
And earlier you said that every individual had their unique endocannabinoid tone, or if you will, like a fingerprint. And I can imagine you take one, cannabis plant makeup for person A, and it'll have a completely potentially opposite effect on person B.
That's exactly correct. But we see that in conventional medicine too, right? As an anesthesiologist, little old ladies come in for surgery. You think they need a lot, you need a little, they would need a lot. And a younger person come in, you think they need a lot, they would need a little. It just depends on their health. And really what's at work there is that endocannabinoid system, right? I didn't know that's what I was dealing with, but that's what I was dealing with. Is what is controlling all this physiology. And it is, I think, I can't stress enough how I think healthcare providers need to jump on this. This is our chance to reclaim our industry back from big pharma. Let's understand the physiology. Let's clinically apply the pharmacology of not just cannabis. You have to talk about all that other stuff coming too, like those psychedelics and all that. The endocannabinoid system explains it all. Even conventional medicines, why they work or why they do not work.
That's fascinating. Now, you did mention earlier how they have measured, endocannabinoid system in the lumbar puncture, spinal fluid. Are they measuring in blood serum? Can I do a blood test and send it somewhere?
Stanford came out with a blood test for anandamide. I haven't seen this test, Stanford has come out with a blood test for anandamide. I don't know if it's standardized yet or not, but I know that they did.
Gotcha. So we're getting close there. So
we're getting closer. Whoever
fluid.
comes up with that got $1 billion market, right? How do you measure that endocannabinoid system tone? That's going to be $1 billion market.
Wow. That's going to be pretty fascinating, especially once we figure out what to do with it. But the best thing to do with it is really what we have been talking about, which you talked about at the outset of the show, is apply some of these natural therapies, healthy nutrition, plant-based diet, sleep, and those types of things, exercise, stress management. So it really gets to some of the global things. And
Right.
I can imagine if we're measuring the endocannabinoid system, we can look at the effects of what we're doing.
That's exactly right.
More accurately.
Well, you go back and you look at pictures over the decades and see what people physically looked like, and you can see the change in people, as the decades went by, as we got away from natural food or doing natural things, and the obesity rate and the type of illnesses we had. I know when I grew up, we made mud pies and ate mud pies. We never got sick.
Yeah.
And you didn't see fat kids either.
Yep.
You might have saw a kid who needed regular pants, but they weren't obese, they were just stocky, right? You didn't see them. But now we have all this weird food and microwaving everything and, society pressures. Look at us now.
It's amazing. One last question I have, and I'm going to get to a few questions from the audience, is we talk about electromagnetic fields and the like, because that's certainly one thing we didn't have so much of. Do we know the effects of electromagnetic fields on the endocannabinoid system, cell phones, and that? Is there any studies looking at that, or is it too early yet?
I haven't seen any studies on any of that, the connection between the two, so I can't speak to that. Believe me, I peruse like ResearchGate every day for the latest articles coming out, because I just love this puzzle, right? But I haven't seen anything to that. But I will say this: I do think they do have an effect on the body. I think we just haven't shown it yet. I'm just thankful I don't live under power lines. I don't live under something that's man-made that's changing my body, right? But I don't know if any studies that have connected to it yet. But I wouldn't doubt that it does make changes.
Someone had a question earlier. Can you be allergic to cannabis? Have you seen any severe cannabis allergies? I haven't heard of any myself, but
yeah. And I have heard of a couple of people, but the first thing I would ask the patient first is let me look at the product, make sure there's no contaminants or toxins or any, and how was it extracted? What method of extraction? Was it a fuel that extracted it? That all makes a difference, how a patient reacts. But I have heard patients who say they are allergic like to CBD or THC, or if they're around it too much, they become allergic to it. And that's entirely possible, right? It's, too much of anything could be, devastating to a particular patient. But what is happening now when I see more patients talk about, CBD doesn't do that for me. CBD makes me buzz, right? So what we're seeing now are the genetic studies that connecting your personal genome, if there are variants that would allow you to make something different or respond to something different, that will explain why you behave a certain way to CBD or THC. Those genetic studies are going to, I'm hoping, will become a part of like doing a normal lab in a cannabis practice, right? If you want to know why your patient doesn't respond the way you expect them to CBD or THC, these genetic studies will tell you, yeah, there's a variant here, a variant enzyme that makes it, or a variant enzyme that makes a receptor to explain why your patient behaves this way.
Interesting. Joy 31608, is CBD oil effective for endocannabinoid deficiencies? I guess it depends on the spectrum, is it?
Yes, it depends on the disease process, what else is going on in that patient. But I will tell you this, CBD and THC work better together than separate. So we don't really promote a lot of isolates, because isolates have a much more narrow window of safety. And we learned that with Epidiolex seizures for kids. It took so much more of the CBD to control those seizures, and we began to see the liver function test start to rise. And thankfully, it's it turns itself around. It's correct when you lower that CBD amount. But that's the difference between using an isolate and using a full spectrum. You're not going to need as much, and you're not going to see the narrow therapeutic window.
Gotcha. So, are you familiar with the Prairie A&M School of Medicine, School of Agriculture Medical Hemp Program?
No, I'm not.
Yeah, they have one there. Dr. Atkins, you familiar with that program? I've heard about it.
Yeah, I am not, and I'm not sure what they're studying right now, or if they have anything with involving cannabinoids. We're not sure about that.
Yeah, I hear they're growing hemp there, and I'll have to investigate. So, Miss Yolanda Williams, you have some homework to do. You got to educate us on that piece of information. But no, seriously, I mean, it seems like there's a lot of science. Now, a lot of people are getting into it commercially. I mean, commercial marijuana is in the foods and that type of thing. How is that impacting the science? Is that, do we need more understanding before we get into this?
Yes, yes. I'm always warning my patients. I mean, you have them putting CBD in yoga tights, yoga pants. I mean, it's everywhere. You can get too much CBD. Once again, the cytochrome P450 system that metabolizes most of our pharmaceutical CBD high levels will tie up your cytochrome P450 system. So you may see increasing levels of those pharmaceutical drugs in the bloodstream, right? I mean, they're getting it in hair shampoos and lotions and clothes and sheets, and it's out of control with what they're doing with the cannabis, with the CBD market. It's totally out of control, and we hate to see it because it's bad for the industry. It's bad for us who really want to see this as a real medicine alternative to pharmaceutical drugs. It's out of control.
Yeah, that's an unfortunate thing. You talked earlier about us physicians taking control of our industry, and I think you're right. It's just that, I mean, I don't know. I guess I'm usually not pessimistic about things, but when you talk about physicians taking control of anything, I become as pessimistic as anybody.
I will tell you, when I went to get my MBA degree, I guess I didn't think about organizational cultures. And I didn't know that medicine had an organizational culture. And it's so different from, the business culture that I was really shocked. And you're right, we are so stoic in what we know and willing to step outside of that box. What I'm starting to do is encouraging my colleagues to go back and read that Hippocratic Oath and see how far we have deviated from the Hippocratic Oath. And if it will bring you back to get you to reconsider, we do no harm first. And if cannabis is a better product for your patient than like Cinepril or something else, you're going to need to think about that, right? Before you just blindly give that pharmaceutical drug that has horrendous side effects. Now, I'm not against conventional medicine. I'm a conventional trained physician, right? I'm an allopathic physician. I was an anesthesiologist, probably one of the most drug pusher, a board certified drug pusher, board certified drug pusher. So we know how to push those drugs, but we also understood physiology and pharmacology, right? We need to get back to understanding. If there's something new, doctors, we need to learn about that. Don't have your patients know more about it than you do, right? And when you start to clinically apply this stuff, you think in terms of, okay, how is this disease? This is a disease process. What's wrong with the endocannabinoid system? How do I fix that endocannabinoid system? How do I fix that bigger picture own? And what in my toolkit is going to do that? So it may be turmeric, or it may be ayahuasca, or it may be a conventional drug that you use, but you're looking at it from the point of view or the perspective of trying to at least slow the process down, if not outright stop the process. And that's certainly true in cancer drugs, and certainly type 2 diabetes, hypertension, obesity. Those are things we should be able to turn around. Heart disease, those are things we should be able to turn around. Even aging, we should be able to turn that around with thinking about health from a different perspective, right? Think about health from the perspective of the endocannabinoid system.
Wow, fascinating. Are there some review articles? Can you point to maybe one or two review articles that kind of give an overview? I mean, you've done an excellent job in this discussion, starting with the science, we started with the blurb of the history. Are there any articles that give an overview that can help someone I can leave with our
You know,
audience?
yeah, I certainly wouldn't. I wouldn't know. I wouldn't remember the title, but I can tell you authors that I absolutely love reading. One is Dr. Ethan Russo. He is a
Okay.
neurologist and just an globally respected. I read everything he writes. Dr. Ethan Russo. I read everything. And then there's a McPartland. He's a DO, and his work is outstanding. Vincent DiMarzo is one of the researchers. He's out of, I think, Italy. Does amazing work. He talks about the endocannabinoid OM, and he first described it in 2014. And then some of the cancer researchers I love reading is, what is their name? God, Manuel Guzman. Oh, and what's her name? Woman's name. Maria Sanchez. 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 And most of these guys are researchers, except for Russo, who's an MD. But they're doing excellent work. And go into ResearchGate and just type in cannabis. Go in PubMed and just type in cannabis or the endocannabinoid system. You'll see thousands of articles far out of numbering anything like conventional medicine. There's more research that's been on the endocannabinoid system than cannabis, than the drugs that we happily and without a second thought, prescribe to our patients.
Wow, wow, fascinating, fascinating. We've got a lot of homework to do. Dr. Atkins, any final
Yes, we
questions?
do. Yes, we
Yeah.
do.
Yes, Dr. Janice, I think Yolanda asked about how can patients open the conversation to their physicians that may have some fear about cannabis. Do you have any tools or references that may help a patient can have their doc consider or to look into the benefits?
What I do is, I tell them, usually I have a patient who is afraid to talk to their doctor, and it's very important that they be totally transparent. Because once again, if you have a patient that's on like anti-epileptic drugs or warfarin, those doctors need to know if they're using CBD because it's going to tap that cytochrome 450 and other metabolizing enzymes, right? So I tell them, look, I'm going to send you a paper, and I want you to take it into your clinician and have them help you understand what that paper is saying, to sort of pique their interest, right? To sort of get them to read a little bit about cannabis. To me, it's sad when a patient knows more about this cannabis than I do. I would be humiliated. And that's actually how I got into it, right? I went to one of these clinics and those patients were asking me questions and I could barely spell the word cannabis. I was so humiliated and embarrassed that I made it my job to learn and to know what they were talking about. I grew up in a very religious family of 15 kids. I was the fourth of 15, and my father was a pastor. You know what that means, right? You didn't do drugs. You didn't talk about drugs. Right? You didn't do that. So I really knew nothing. Even as an anesthesiologist, I knew nothing. So I made it my business, but I'm a curious person. I always want to look under that hood. But a lot of us are just still too afraid, whether it's for our licenses or religious purposes, all of that. But we have to put that aside, right? Do no harm. So if your patient are asking about it, let's talk to them about it. Take that article in and say, doctor, I read this. Can you help me understand this? And sort of so you can get them to read something about it. That's my trick I usually give to patients.
That's amazing. Shonda's Real Food and Drinks, she has an 80-year-old friend recovered from anesthesia better than she does. So she's when she undergoes anesthesia out for days, for example, like a colonoscopy. So this kind of covers your whole scope. So what may be going on with her?
Maybe the anesthesiologist gave her too much. That's my first. That's my first thing. But once again, I think a lot of it does depend on who you are, your fear factor. I know as an anesthesiologist, I would love to see this study using CBD preoperatively and postoperatively. Preoperatively to fight anxiety and that fear that gets your system all tight, throws that endocannabinoid system out of whack because you're terrified. And then post-operatively, right, again, handling anxiety and fear and pain. Maybe you're need less of those opiates in recovery, right? But also it helps with your recovery process itself. So that would have been an interesting study. But once again, everybody is starting from a different place, and you may need more than that 80-year-old person. That 80-year-old person may have a healthier endocannabinoid tone. It's just so many factors determine, how you respond to anesthesia. So let me say this too. It does depend on the anesthesiologist who needs to go in here and make sure that you're comfortable with what's happening so that fear decreases. Once again, we're working out endocannabinoid system, right? Calm that body down.
Okay, so there are other aspects. That's a good point. So the other aspects are going in. We're just looking at the anesthesia, but in terms of your approach to the procedure itself, you're stimulating a lot of things within your endocannabinoid system and
That's
central nervous
right.
system and the like, and it can have a
Absolutely.
postoperative effect.
That's
Interesting,
right.
interesting. I like
Absolutely.
that. So good bedside manner, lots of laughter, etc. Uh,
Thumbs up. Double
Zorro
thumb.
Zorro wants to know: do you prescribe smoking it or some other forms?
And that's most patients still think that smoking is the only way we use it, but that's absolutely not true. I don't personally prescribe smoking. I mean, we call it the pulmonaries. There's two ways you can do it. You can smoke it or you can vape it. When you smoke it, you're heating it at a high temperature that you're coming down with those polyhydrocarbons that are toxic to
Mm.
your lungs. You're making formaldehyde and things that are just very bad for your lungs. When you're vaping it, you're not heating it to the same temperature, so you have less of those toxic byproducts to stimulate the lungs. But with that being said, for example, if I have a patient who have a problem with insomnia, they have a problem getting to sleep and staying asleep, I may tell them I want you to vape because it's a quick onset of action within minutes and it's going to last 2 hours. And I'll tell them take an edible or tincture that's going to last the 6 to 8 hours. So they get to sleep quickly and they stay asleep. So it really depends on your patient and what your patients need. But generally, we don't ask people to smoke, particularly in these times of COVID when the lungs are so the entry for this COVID virus. We try to get them away from smoking.
Gotcha. So you use it to some extent, limited forms to help us sleep, but you'll still use something that's oral
Yes,
that
no,
tends to be more
layered.
long acting. So you do use cannabis to help with sleep. Does the
Absolutely.
person, well, let me ask you this. So when you use it to help with sleep, does it get to a point where they no longer need the cannabis and their system takes over?
Well, it
Or you
depends on the
wean them off?
Yeah, it depends on the patient again, right? We call it, when you sort of prime your endocannabinoid system and get it back to function so it does the job that it does. And most patients do better and they need less and less. But the cannabinoids we use for sleep are, CBN, which is a breakdown product of THC. We also use CBD in low doses are very stimulating CBD. So high doses of CBD will help you to sleep. And the opposite is true with THC, right? Low dose of THC will help you relax. High dose produce anxiety and all of that. So what we try to do is figure out what the patient problems are, and then give them the right cannabinoid profile. So I may tell them I want you to use this much CBD, this much THC, and this much CBN for your sleep, right? And then I'm going to put the terpenes on top of that helps you relax and go to sleep. Now, we've just been talking about the cannabinoids. Those terpenes are awfully important. And the
Mm.
terpenes are the aromatic compounds that give the odor and the aroma and flavor to vegetables and fruits. But we have the daytime terpenes and nighttime terpenes. Nighttime are like linalool, lavender. There's a reason they use it in spas and things. And myrcene, they help a patient to relax. And they support those cannabinoids. They determine how those cannabinoids are going to work. If I have a patient that needs to be alert during the day, then I'll give them CBD and something like alpha pinene, which is alerting and stimulating, improve function of your mind, the focus of your mind. Limonene, which is like lemon, elevate their mood, right? Help them to relax, focus, clear their minds. So those things need to be thought about when you're talking about any kind of disease process, not just the cannabinoids, but what terpene profiles are being used to reach that end result.
This is wonderful. This is wonderful. You're giving us an excellent teaser into next week. We're not going to spoil the next week. Uh, and this is great stuff because, again, very fascinating. And the audience, just give Dr. Knox a digital round of applause, guys. The thing is that I love the points that you make because, we really need to manage health from an underlying process, a physiological process, an understanding of physiological process, and understanding the outward, um, problems that are affecting that, and address it from the outside in and the inside out. And it starts with the understanding of this process. And I love the way you describe the physiology of it. And this is an exciting area that I really look forward to learning more about. So, next week we are going to talk about the clinical aspects, and as Dr. Knox started getting into it, how she treats different disorders. So we're going to talk about different chronic illnesses. Some of you had questions that were related to that, and how we managed it from an endocannabinoid system with natural foods and herbs and substances and the like. So for those of you, give it the thumbs up. Dr. Knox, Dr. Axon, I'll see you backstage as I close out. Thank you very much. And again, as always, I learn a lot in these shows, and I hope you've learned a lot too. And if this has been very beneficial to you, of course, hit the like button, give us a thumbs up, and obviously share this with anyone and any loved one or friends that could benefit from this information. If you haven't subscribed, please subscribe and hit the notification button. You'll get more information from us as we put together, these talks that are meant to empower you, to inform you to take better care of yourself and strengthen your knowledge. And the more you know about your body, the more you become an expert in terms of helping yourself. Someone like me should only be a consultant to help you tweak, fine tune things. We want to empower you to be knowledgeable, not to rely on, some specialist, someone in a white coat to say you have a disease or have a diagnosis or not, or wait for some lab tests that, say this, that, and the other. But understand your body, understand how to maintain yourself, understand how to enhance your health and enhance your quality of life. So we look forward to next week's our third session on the endocannabinoid system. We're going to look at the clinical application. So please join us then. And until that time, keep it fresh, natural, and live.